Hello everyone. So let's start with the discussion of face and scalp region. So in this session, I am going to talk about all the layers of the scalp, the muscles of face, the nerve supply, the arterial supply, about the venous drainage of the face and the scalp. So let's start with the session. So it's very easy to memorize the layers of the scalp. We can just spell the word scalp and we will get the layers of the scalp. What is the scalp spelling? SCALP. So here S stands for the skin. The another C is for the connective tissue layer, that is the subcutaneous or connective tissue layer, and A for the aponeurotic layer, which is the aponeurosis of occipitofrontalis muscle belly. The frontal belly is lying anteriorly and that of the occipital bellies is lying posteriorly in the skull region, and in between the two bellies are merging with each other, and that is called as aponeurosis of occipitofrontalis muscle belly. If I talk about L, that is the loose areolar tissue, and P here stands for the pericranium. So just spell the word scalp and you can know the layers of the scalp. What is important for us is to know the significance of each of this layer of the scalp. So let's start with that. Now once again I want to see you another dissected part, a schematic dissected part, which will help you to understand the layers. So here the first layer is the skin, then we have got the subcutaneous layer, here the musculoaponeurotic layer, and we have got the loose connective tissue layer, and we have got the periosteum, which is lying over the deep fascia. So these are the 5 layers, and let's start with the discussion of individual layers. So let's start with the first. So the first layer is the skin, and as I told you, the whole of the scalp, you can see also it is covered by hairs. So it is having hair except over the forehead. Actually, it is firmly adherent. So there the skin of the scalp is thick, hairy, except it is not very much hairy if you compare on the forehead. It is firmly adherent to. I just want you to tell that if I am talking about the 5 layers, you can see there is a skin and then there is a connective tissue layer which is dense, and then the 4th layer is also connective tissue layer, but that is loose. Here it is dense and it is merging with the 3rd layer of the scalp, that is the aponeurotic layer. So only the 3 layers together, the skin, the dense connective tissue layer and that of the aponeurotic layer of the occipitofrontalis muscle belly merged together and is called as the scalp layer proper or surgical layer of the scalp. Now, it is dense. I just want everybody to understand that it is dense. So, it is adherent. This layer is adherent with the epicranial aponeurosis and firmly adherent to the connective tissue of the superficial fascia, as in case of palm and soles. The next layer is the connective tissue layer, that is dense. As I told you, this connective tissue layer is dense connective tissue layer. It is made of dense fibrous connective tissue layer which is binding with the muscle bellies of occipitofrontalis muscle belly. Now, the 3rd layer is the occipitofrontalis muscle, which is having the aponeurotic layer in the middle part. So I just want everybody to concentrate on the schematic diagram which will help you to understand this bellies. So I just want to enlarge this. So when I am enlarging this image, you can clearly see the frontalis bellies. So what you can appreciate in this diagram, that the frontalis muscle belly is lying anteriorly. So this is F for the frontalis muscle belly and this is O for the occipital muscle belly, and in between this is the aponeurotic layer, and this aponeurotic layer is the aponeurotic layer where the 2 bellies are merging with each other. Now, it's important to understand about these muscles. So, exactly we have to know about the attachment and the nerve supply. So, if I am talking about the occipitofrontalis aponeurosis, it is consist of 2 frontal bellies and it is consist of 2 occipital bellies. So, together we have got the 4 bellies. Now, the aponeurosis of the occipitofrontalis muscle belly is also called as epicranial aponeurosis or Galea aponeurotica. The other name which can be used for it is Galea aponeurotic layer or epicranial aponeurosis. Now, here the next layer is the occipitalis belly. I just also want everybody to understand that if I talk, I am coming to the occipitalis belly, but I just want that frontal bellies, if you talk about the origin of this frontal bellies, these are originating from the skin and the connective tissue, that is subconnective tissues, subcutaneous tissues, which is around the eyebrows and the root of nose. So what you can see, the frontal bellies anteriorly is merging with the eyebrows and the root of nose. It is not having any bony attachment anteriorly, and it is inserted in which part? It is inserted in epicranial aponeurosis, which is lying in front of coronal suture in the skull. In the midline, we have got the sagittal suture and we have got the coronal suture. So it is merging with epicranial aponeurosis. It is having no bony attachment. It is very important to highlight this point because this will help us to understand why black eye occurs, and there is the clinical aspect related to this. So it's very important for you to note down that the frontal bellies is originating from the area of the skin and subcutaneous tissue over the eyebrows and the root of nose. It is not having any kind of bony attachment. Now, if I am talking about the frontalis muscle belly, it is merging with the muscles. So, it is merging with the muscle of the facial expression, that is the corrugator superciliary. So, it is merging with procerus, corrugator superciliary and orbicularis oculi muscle. So, actually in our face, the muscle of facial expression, we have got different categories of muscles of facial expression, which detail I will give you. If I am talking about the muscles which is lying around this eyeball, and we have got this circular muscle, sphincteric muscle in the around here, around the eyeball, we have got the orbicularis oculi, we have got corrugator superciliary muscle and procerus muscle. The frontal bellies are longer, wider, and it is united along its medial border. Now, I just want everybody to pay attention to the occipital belly. The occipital bellies arises from, if you see the posterior aspect of the skull, you can appreciate the nuchal line. You can appreciate superior nuchal line. So, from the lateral 2/3 of the superior nuchal line, the occipital bellies is traversing forward and it is inserted into epicranial aponeurosis. So, where it is inserted? It is inserted in epicranial aponeurosis. The two occipital bellies are separated from each other by a considerable gap, and this gap is filled with epicranial aponeurosis. This gap is filled with epicranial aponeurosis. Okay. So, we have done with these two muscle bellies. I just want once again, please come to the image where you can appreciate the occipital bellies, which is arising from the superior nuchal line. So, which will arise from the superior nuchal line and merging with the aponeurotic layer. The nerve supply of these two bellies are also important. Actually, both the frontal bellies and the occipital bellies of fronto-occipitalis muscle is innervated by branch from the facial nerve. Temporal branch of facial nerve is innervating the frontal bellies, and posterior auricular branch of the facial nerve is innervating the occipital belly. So, I just want everybody to note down this. Then we'll be moving to the next. So, here you can just write down occipital bellies of occipitofrontalis muscle is innervated by posterior auricular branch of facial nerve. Okay, and if I talk about the frontal bellies, please write down frontal bellies of occipitofrontalis muscle is innervated by temporal branch of facial nerve. So, done with this. Now, let's talk about the fourth layer. The fourth layer is loose areolar tissue or loose connective tissue layer, and it is signified as the dangerous layer of the scalp. The reason why it is called as dangerous layer of the scalp is emissary vein is traversing through it. So, as the name suggests, this is consists of loose areolar tissue layer, and it is also used as a natural plane of cleavage during craniotomy operation. So, the layer is traversed by emissary vein, and the significance of emissary vein, clinical importance of emissary vein is that this is connecting the veins on the external aspect of the skull and the face with that of the dural venous sinus. So, that means it can lead the infection in the interior of the cranium. So, and this is the reason it is also called as the dangerous layer of the scalp. So, loose areolar tissue is signified as the dangerous layer of scalp.